Ready, in the interest of time, we'll get going. Hi to everybody. I'm Julie Stacku, for those who don't know me, because I think we have some external people. I'm the provincial lead for plasma cell dyscrasias, aka multiple myeloma. Thank you for joining for this inaugural myeloma education event. Very fortunate to have Dr. James MacMillan, who is a palliative care physician and family physician. I'm going to get James to introduce himself because we're going to put this presentation on our myeloma healthcare providers website. And if you haven't seen it and haven't gone to it, please go to it and check it out. There's lots of great resources. So I want James to introduce himself so it's there on the video. At the end, Dr. MacMillan will have a QR code for the talk evaluation, mainly for us to see what you might want for future topics for our ongoing education series. I will just give a shout out to Dr. MacMillan, who not only has done a lot of stuff from palliative care and helped this model of care program, but has come to all of our First Nations and Métis working group meetings to kind of lend an ear and support that way. So he's really been instrumental in helping us move through that model of care. And I thank him very much for that. So without further ado, I think that I'll turn it over to Dr. MacMillan. And I know at the end, there'll be lots of opportunities to ask questions. If you want to throw things in the chat, you can do that too. So I'm going to go off camera and go off mute and turn it over to James.
Great. Okay, well, thanks very much. Again, I'm James MacMillan, and I practice palliative medicine here in Saskatoon, as well as in the Integrated North with the SHA palliative team there. And yeah, I'm fortunate and excited to be a small part of the monoclonal gammopathy pathway project. So I do thank Dr. Stacku for the vision behind the project, and not only to her, but to Miriam and so many others who are making it a reality. One of the pillars of the care model is early pain and symptom management and palliative support. So I'm grateful to be a part of the team who's supporting that work. And I recognize that today there are probably several individuals from a variety of disciplines and different care settings. So some of the material that I present might be familiar to some, perhaps new to others, maybe more relevant to some. Nonetheless, I think all of us who are supporting patients with multiple myeloma, we do have a role to play in supportive care and symptom management. So I hope this session, if nothing else, enables us to feel just a little bit more confident as we do that. We do have a lot of material to cover, and we will move quickly. But again, this session is being recorded, and I'll also make sure that the slides are available. So if there's anything that seems noteworthy to you, don't feel that you have to necessarily write it down. So I live and work here in a land where over countless generations, families and communities have supported and cared for loved ones with serious illnesses. And Treaty 6 territory is a land where traditional teachings have recognized the interconnectedness of life and really prioritize kind of an integrated vision of us as humans in all our multiple dimensions. And that understanding really overlaps so well with what palliative care aspires to achieve. So as we share this land, I'm committed to walk alongside one another, to learn, advocate, reconcile, and to grow in compassion and solidarity as I seek to provide holistic care. I don't have any conflicts of interest to declare. The objectives have already been shared with you in advance, but I put them up here. I will also just note that because of sort of the scope of the objectives, I am not going to specifically be talking about the symptom management for fatigue and the GI symptoms, but I do have slides prepared that can be shared with the learning package afterwards. And because this is a recorded session, it is going to primarily just going to be didactic. You're just going to have to endure hearing me chat here. We will go through a lot of material, but I certainly do want to hear from you. So if you have questions or comments or disagreements, feel free to send me an email here. And I can also stick around after the 1 hour session if there are people who want to chat some more. But we'll dive right in. Again, it is a lot of material, so buckle your seatbelt and let's get going. Again, just recognizing that we probably have a variety of individuals and disciplines and settings present. So I'm just going to give a little bit of background information to make sure that we're all on the same page. Again, knowing that some of this will be very familiar to many of you. But multiple myeloma is the second most common hematological cancer. And in 2024, there were over 4,000 new cases and nearly 1,800 deaths from multiple myeloma. Median age of diagnosis is 70 years. And while it is a disease that remains incurable, there have been tremendous gains through like just really fascinating research and development, particularly over the last couple of decades. This is just one schematic from Myeloma Canada that shows some of the milestone treatment modalities that have been introduced. And with that, survival has really increased. This is US data, but in 2024, the 5-year survival was 61%. We're regularly caring for patients who will live for many years, 10 or more years. So with the number of patients living and as new therapies are developed and our population is aging, there just are simply more patients who are living with multiple myeloma. And at the same time, of the hematologic malignancies, it has been shown to be associated with the greatest symptom burden in a population that's living quite long, and also associated with the poorest quality of life of the hematologic malignancies. So that being the case, it's really imperative that quality of life is at the core of our management. Again, just a quick overview so we're all on the same page. Multiple myeloma, this is a disorder where the B lymphocyte that matures into plasma cells is damaged and it's reproducing plasma cells uncontrollably. And so as a result of that, that high abnormal number of plasma cells kind of crowd out other blood cells, including red blood cells and platelets, other healthy cells. And then also it's producing the monoclonal protein or the M protein. It's an antibody, and this can lead to complications. This is a lovely graph from the Cancer Agency's website that Julie referenced. Consequently, there are the so-called CRAB complications. So hypercalcemia, which is typically multiple myeloma-induced bone demineralization. A good number of the patients at the time of diagnosis already have an increased creatinine and renal insufficiency. This is largely because of light chain cast nephropathy, with potentially a component from hypercalcemia. Anemia can be because of the bone marrow replacement, that crowding out effect of the plasma cells, as well as decreased EPO production from the chronic kidney disease that can develop. And then the B is the bone lesions. So this is one of the kind of hallmark features. The myeloma cells are invading the bone and causing multiple areas of damage that weaken the bone and cause the so-called lytic lesions. Sometimes those cells can coalesce into a plasmacytoma in the bone or soft tissue as a tumor. So I just want to put this up. This is a great tool that the Myeloma Working Group has put together just for anyone involved in patient-facing care to have this on the radar. Think myeloma. If there are some of those symptoms, certainly if there are any of the CRAB and organ complications. I'll just put up here for reference the so-called SLIM criteria, SLM, so greater than 60% of clonal plasma cells, or the ratio being greater than 100, or more than one bone lesion on an MRI. Those are so-called myeloma defining events. Now, there are some precursor syndromes that we can recognize. So MGUS, this is a premalignancy, often asymptomatic. And as people get older, they're at a higher risk of developing this. Those who have it, a risk of progression to myeloma is about 1% per year. The so-called smoldering multiple myeloma is also generally asymptomatic. It could be viewed as kind of a transition state between MGUS and multiple myeloma, and also a higher risk of progression. This is merely just for reference for those of you who just want to identify the defining features that separate these conditions. So I now want to dive into, which is a little bit of that background there, dive into the main topic at hand, which are what are some of our palliative care opportunities as we're supporting patients with multiple myeloma. First of all, just recognize that of all patients in the oncological world, generally those with hematological cancers tend to have the lowest rates of palliative care involvement. And when palliative care is involved, often referrals are happening towards the end of life, historically. There are some studies that have suggested the timeline between first palliative care consultation and patient's death had a median time of 12 days. Now, thankfully, I think this is changing, but it is still just a reality that maybe this is a patient population that could be tapped into a little bit more. There are various reasons in the literature for potential late involvement. Some of it is just the nature of the illness. It can be unpredictable, and there can be these really sudden transitions from a stable to more of a unstable late stage disease. And I think really fundamentally, there's a lot of misperceptions among the general public, the patients that we care for, and perhaps some of our colleagues about what palliative care is and what it isn't. For some people, they view it strictly as end of life care, just kind of the final days to weeks of life. And this is sort of illustrated by a metaphor that I often use with patients. There are two types of light switches. There's the simple on-off switch, and then there's the dimmer switch. So the on-off switch would represent kind of a historical understanding of palliative care represented in this diagram. So this is the idea that somebody's got a life-limiting illness. They're having treatments to try to control the disease. And they go through the first, second line, third line treatments, and then ultimately reach a point where there's no further treatment options. That is when the switch is flipped, the on-off switch. Palliative care is involved for kind of the terminal phase, final days to weeks. Now, that's an old model. The literature suggests that a better model would be more of what we could think of as a dimmer switch. This is the idea that early palliative care involvement, whenever somebody has a life-limiting, incurable illness, and that palliative care involvement or the palliative approach to care can coexist with the disease-modifying treatment. So as time goes by, the involvement may fade in more intensely for certain periods, maybe with symptom management, goals of care conversations, maybe fade out for a bit, but over time gradually fading in more as the disease-modifying treatments are fading out. And so it's also diagrammed this way, which is why it's sometimes called the bow tie model of palliative care. This overlaps well with the WHO definition of palliative care. I just want to highlight a couple of their phrases in their definition where they emphasize that early involvement in conjunction with other therapies, and that in so doing, it can improve the quality of life and perhaps positively influence the course of the illness. There is actually a great deal of evidence to support this approach. I'll just draw attention to a couple of meta-analyses and systematic reviews of what early involvement of palliative care yields for patients. Now, this is in the solid organ malignancy, but in those who had early integration alongside their standard oncological care, the bottom line is they had better quality of life, both physical symptom-wise and psychological, and they actually lived longer, which is great because sometimes patients are worried that having a palliative approach to care necessarily means they will die more quickly. And if anything, it's a neutral effect or even a positive effect where they live longer. In addition, caregivers have better outcome, both from mental health while they're caregiving and perhaps also while they're grieving. So that's the solid organ malignancies. Well, what about, is there data to support this idea in hematologic malignancies? Well, this is just a couple of randomized trials that were in different phases, and they were looking at having inpatient palliative care involvement at the time of stem cell transplantation. So there was the initial trial for the first 2 weeks, and then a follow-up at 3 and 6 months. And those patients who were randomized and had the early palliative care involvement concurrently with their transplant care. So at 2 weeks, there was less of a decline in their quality of life, better depression and anxiety scores, better symptom control. At 3 months, those improvements in quality of life and depression remained compared to the control group. And at 6 months, the improvements in depression and any PTSD that had been developed were sustained as well. So that's encouraging. This is just one other study that might be worthwhile to note. So this was a retrospective study of patients attending a multiple myeloma palliative care clinic over the course of a year. And those patients reporting moderate to severe pain significantly decreased. And they reported less pain interference with their general activity, with their sleep and their mood. Other physical symptoms, as well as other emotional symptoms, were also improved compared to those who did not have that concurrent care, and less depression as well. So while we don't maybe have as much data in the hematological world, I think the data we do have is encouraging to say that integrating an early palliative approach to care may be beneficial. Now, at the same time, I've certainly encountered patients who bristle at the word palliative or at the notion of having a palliative approach to care. It can be a scary term. And so if the light switch metaphor is ineffective, another metaphor that sometimes can be useful for the patient is the so-called umbrella metaphor. So this is the idea where early palliative care is presented as an umbrella to have on hand in case of the rain. This is developed by some of our palliative care colleagues in Canada and was published in JAMA Oncology a few years ago. And the idea is that anyone who has a serious illness, like a cancer, is worried about the metaphorical rain, right? Which can represent the physical, emotional, and existential problems that can arise in the context of their illness. And so for those people who say it's too early, I don't want palliative care involved, I'm worried that it's going to cause more harm or hasten my death, emphasizing that, like the weather, the course of a cancer can be unpredictable. There is some inherent unpredictability, as well as potential unexpected complications. And so having an umbrella on hand in case there is rain can be useful. And again, for those who fear that palliative care actually hastens death, just sort of drawing the analogy, while an umbrella is very intimately associated with the rain, the umbrella doesn't cause the rain. It's just that people pull it out when it is raining. So it's the umbrella, not the rain. And I kind of like that idea because it actually etymologically corresponds with the word palliative, which from the Latin means to cloak or to cover. It was kind of this idea of like an extra layer of protection or shielding. If you prefer memes to metaphors, this is one meme that I saw, which I think resonates. So one thing I want to emphasize is that while palliative care does involve specialist clinicians and specialist teams and specialist units, it really is not just a discipline, though. It is an approach to care that is all of our opportunity and all of our responsibility. So no matter what your discipline, or if you're caring for patients who have life-limiting illnesses, you can and should be involved in a palliative approach to care. Now, sometimes a patient can continue sort of at that generalist level of palliative care all along through their illness trajectory. Many can. Some, they go up to a specialty level for a time and then are referred back down to the generalist level. Others require ongoing specialist involvement. But the point being is we all have a part to play. And I hope that through endeavors such as this, your confidence in providing that palliative approach to care will be enhanced. So what are some of the main opportunities that we could engage patients with? Well, certainly kind of linking up with palliative care teams and services, being involved in advanced care planning, goals of care conversations, and then certainly symptom management, as well as broader psychosocial support. So let's talk about each of these a bit. So I think, again, recognizing that any patients who have a life-limiting illness benefit from an early integration of a palliative approach to care. Although, again, our myeloma patients may live for a long time, potentially over 10 years, it is properly understood as a life-limiting, incurable illness, and so could qualify for referral to a palliative care program. All the treatments that are being offered are palliative in nature, at least at this point. So while that's true, at the same time, that doesn't necessarily mean that every patient at every stage of their illness qualifies for all the services that fall under the palliative care umbrella. So for instance, palliative drug coverage or home oxygen or some of the financial like waiving of home care fees. So in Saskatchewan, the Ministry of Health, it distinguishes between what they call early/intermediate or stable palliative care and end-stage palliative care. This is just a bit of a diagram. It's very busy, but I only bring it up to say that there are many services, including like some wound care supplies, bowel supplies, dietary supplies, various things that are covered by both groups. So even if a patient might not qualify for waiving of home care fees if they're not end-stage palliative, nonetheless, there are lots of things that can be covered. I think we should talk about palliative drug coverage. So many of you probably know, but this is a program where people who are in the late stage of their illness can have coverage of all medications on the formulary, including the dispensing fees. The one thing, though, we just should recognize is they talk about when it's sort of late stage, when life expectancy is measured in months. Now, they don't specify if that's 3 months, 6 months, 12 months, 24 months. But I think probably we would have to recognize that some of our patients, maybe very early in their multiple myeloma journey, might not qualify for palliative drug coverage, but then later would as time goes by. Shifting gears, advanced care planning is very central. Now, I'm sure many of us know what this is, but just to bring it together, it's not an event, it's a process, ongoing process of thinking about what really matters to a person, their priorities, and then having kind of a verbal or written summary about the care that they would want. And it's in particular for when they can't express themselves. So it doesn't take effect unless they can't express themselves. Central to this is appointing a health proxy. This is someone who would be their voice if they couldn't speak for themselves. And as I said before, this is not just a one-time document or a one-time conversation. It really should be a living, ongoing conversation that is potentially changing as one's situation changes. The advantages are it really takes the pressure off loved ones, can reduce stress, make potential disagreements among family members, and fundamentally, it allows us to be more likely to honor one's wishes, both as providers and family. It doesn't require a lawyer. There's no legal fees to have this, and there are lots of templates available. So the SHA has the My Voice template, which many are familiar with. That is one among many. It doesn't have to be on a specific template. So long as it's signed, dated, and witnessed, it is valid. Another part of this kind of conversations is goals of care conversation. So this is more talking about kind of in the present with the patient who is able to participate in the conversation. This is really, really central. Many of us have probably been surprised when we have been caring for patients for a long time and we realize that they actually don't have a clear understanding of their illness. Many have quite partial or perhaps inaccurate understandings of their illness. So it's essential to clarify what do they understand, and also really to clarify how do you like information shared. Some people, they're the detail. They want all the minutia, the fine details, the reports. Others, they just like high level, basic. And this is essential to have effective goals of care conversations. The reality is, as tricky as and maybe as difficult as some of these conversations can be, being transparent and honest is what most people want. And they deserve to know about what the natural history is, where they're at in their trajectory, and what they might expect in the future. Sadly, these conversations too often wait until a crisis period when it's so much better if the conversations are having further upstream in times of stability and then being revisited and sort of clarified again in moments of crisis. So this diagram from Myeloma Canada, again, just shows how this trajectory of relapses and remissions, often many of our patients will have this. And so too often we wait into the relapse to have the conversation, whereas it's in the remission time when it's really helpful to have these conversations and then revisiting the conversations in the time of relapse, especially as you're talking about treatment plans, but not reserving it only for those scenarios. The Serious Illness Conversation Guide is a document and a process that has been validated and well studied, and it's been shown to be effective in improving and enhancing communication. It's got a nice format as well as specific language, ideas, phrases, sentences that can be used to guide the conversation. I'll just pull out a few because I think it might be something you could integrate into your practice. It can be difficult to predict what will happen with your illness. I hope you will continue to live well and for a long time, but I'm worried that you could get sick quickly. And I think it's important to prepare for that possibility. I hope this is not the case, but I'm worried that this might be as strong as you will feel. If you become sicker, how much are you willing to go through for the possibility of gaining more time? Or what are your most important goals if your health situation worsens? What are your worries, your biggest fears about the future? Maybe, is there anything going on in your life outside the hospital that I should know about that are a source of fear and worry? And what are your sources of strength? What gives you strength as you think about the future with your illness? So that is really essential, and I think we all play a role in being involved in those conversations. I want to shift now again to specifically talk about symptom management, and we will today be talking about pain. Again, I do have supplemental slides that will be included for fatigue and GI symptoms, but we're going to put our energy into talking about pain. So the reality is that patients can and often do suffer from pain at various stages of their disease. And pain is associated with a really negative impact on quality of life, unsurprisingly. And adequate pain control is not only good for quality of life, but it actually can help improve treatment adherence. It can improve their overall functioning, their social engagement, and their psychological outlook. And because inadequately treated pain often leads to poor mobility, reduced mobility, that can be a risk factor for venous thromboembolism, pneumonia, pressure sores. So many reasons to make diligent management of pain a priority. We can talk about some broad categories of pain in myeloma patients. So bone disease, neuropathy that could be disease-related or chemo-induced, as well as herpetic and post-herpetic neuralgia, and then the broader kind of multidimensional chronic pain aspect, as well as potentially pain from just complications that they have, infection or clot. I will just draw to your attention that if this is maybe a topic that is somewhat new to you, that you're wanting to explore and learn more, the College of Medicine, in conjunction with Sask Cancer, have put together these oncology education modules. And there is one module among them that is cancer-related pain management that I was able to help support and develop. And so I will be borrowing some information from this, but if you want to go into more depth, if this is something that is newer for you, that might be a resource to explore. So let's talk about bone disease. As I mentioned, this is, again, like one of the cardinal complications. The vast majority of patients do develop lytic lesions, and that is because of this dysregulation where there's increased breakdown and decreased rebuilding of bone. And those who have lytic lesions, again, the vast majority of them suffer with bone pain that can often be in the moderate to severe category. The literature talks about so-called SREs, or skeletal-related events, and this is pathological or compression fractures, hypercalcemia, a spinal cord compression, which could be from a plasmacytoma or bone fragments, and then any need for radiotherapy or bone surgery. Those SREs have been shown to reduce overall survival. They can be a source of chronic and severe pain, reducing mobility, quality of life, and social aspects of a person's life. So while today we're mainly talking about treatment of pain, I just want to flag that prevention of pain is important too. So again, if there are lytic lesions established, this is why the oncology team is prioritizing trying to promote bone health, prevent new lesions, accelerate healing. So this central to this is often bisphosphonates. The literature suggests that the IV agents are preferable to oral agents, commonly see zoledronic acid. Again, just recognizing it does require renal dosing, and our patients are at risk of developing chronic kidney disease or perhaps have it already. The rankle inhibitor, denosumab, is also often used. So just something to flag for prevention. But in terms of management of existing symptoms, we're talking about pain here, but this is sort of an approach, again, it applies to any symptom, whether it's dyspnea, nausea, delirium. I think the first important thing is to clarify the goals of care. So knowing where a person's at in their illness trajectory, the location of care that's acceptable to them, types of interventions that are acceptable to them, their values, their wishes, because that is going to inform your subsequent steps. So assessment, you're then through history, physical, and investigations, identifying potential causes and your interventions. So I think clarifying goals of care is essential. But we're going to spend a lot of time just more talking about the interventions. So one metaphor that I sometimes use for patients is if you have pain, that's kind of like your engine light going on. And there are two ways to get your engine light off. One is to try to go fix the engine, and the other is to cut the wire to the light so it doesn't illuminate. So again, this idea of trying to reverse reversible causes, if that is possible, and if it's in keeping with their goals of care, that's trying to fix the engine, okay? Now, sometimes you can't fix the engine, or the patient doesn't want attempts to fix the engine. It's too invasive, or requires a transfer somewhere, or it's not in keeping with their wishes. So that's when we're talking about cutting the wire, just trying to reduce the perception of the symptom. That involves both non-pharmacologic and pharmacologic strategies, as well as education, which is really central. So we'll go through these. The WHO analgesic ladder is sort of just another framework that kind of establishes some of these principles. So first of all, I want to talk about just some of the non-pharmacologic strategies, and particularly exercise, radiotherapy, and surgery. So exercise, there have been some surveys that have done where a good portion of clinicians are nervous about recommending exercise to patients because of the potential, of bone disease. But unless there's like really compelling reason not to, generally the data suggests that mild to moderate exercise is beneficial. It may improve their general health, their mental health. Some precautions to be aware of, again, if they're neutropenic, avoiding exercise scenarios where, potentially increase infectious risks like large gym classes, potential for activities that would cause more bruising and bleeding if there's thrombocytopenia. So certainly avoiding contact sports. And then if somebody has a lesion that is potentially approaching a higher risk of fracture, like, a lesion in a long weight-bearing bone, then of course being sensitive to that. This is just a systematic review that was done of 7 different studies. And the bottom line is all the studies concluded that exercise was safe. There were 0 serious adverse effects and only 4 mild adverse effects attributed to exercise. So generally safe. It's generally feasible is what their conclusion was. They did say, based on the data that they had, not tons of evidence to talk about like what is the real impact in patients with multiple myeloma. But there is other data in other settings to suggest that probably it's useful. Now, I'm not an exercise therapist. I'm not a physiotherapist, so I often don't have my own specific advice for this. But Myeloma Canada, it is just amazing in terms of the resources it has for patients, including exercise programs. So they've got these handouts that you can download or just look at on the web. They've got videos that describe and demonstrate safe exercise regimens. So this should be a part of a patient's pain management program. Shifting to radiotherapy. So this is specifically for pain I want to talk about. And generally the data suggests that it is effective for pain. We know that there's a delay before patients experience the effect, but some data suggests that up to half of patients within 2 weeks will report pain relief, and it has been shown to reduce analgesic use. At the same time, we recognize that we really have to preserve bone marrow function. And so if you're just using it for pain alone, you have to be cautious, especially for those who are early in the disease course. So what would be some potential indications? Well, again, I'm not a radiation oncologist, but some of the papers suggest that if there's a localized lesion that is like a definite source of pain that has been refractory to systemic therapy and inadequately treated with analgesics, that could be an indication. And quite good response rates in the literature at both 1 and 2 year marks. Certainly, if there's a spinal cord compression or an impending spinal cord compression, especially if it's due to a plasmacytoma, if it's an unstable bony situation with retropulsed bone, then surgery would be more indicated if the patient is otherwise eligible. Speaking of surgery, let's just talk about this a little bit. So there are various roles for surgery. So certainly if there's an acute fracture that would require surgical repair, so a wrist or a hip or so forth, but also when there are lesions that could potentially result in a fracture, if they're at higher risk, especially in a weight-bearing bone like the femur. So this is prophylactic fixation. Again, for some spinal cord compressions, especially if it's retropulsed bone, but also just for stable vertebral compression fractures that are inadequately responding to systemic treatment and analgesics. So the data and the literature suggests that vertebroplasty and kyphoplasty can be effective strategies. If you're unfamiliar with this, it's a minimally invasive percutaneous procedure, vertebroplasty, where bone cement is injected into the vertebral body and just providing sort of some filler and stability to that area of fragility. The kyphoplasty is a similar procedure, but prior to the cement being injected, a balloon is inflated just to expand the cavity. Both techniques have been associated with rapid pain relief, improved mobility, better performance status, and overall are quite safe. And again, they're minimally invasive. Now, in some centers, this procedure is done by both interventional radiology and spine surgery. I did just recently chat with one of the spine colleagues, and to his knowledge, he said it's largely done by spine here locally. Okay, I want to move on to the idea of psychosocial contributors to the pain experience. This is, again, just recognizing that pain is fundamentally, it's a subjective experience, and there's so many things that contribute to one's experience of pain. Various psychological, context, family, financial factors that can impact and modulate a person's perception of pain, as well as the meaning that they assign to pain. So It's not merely about what's going on at the tissue level, it's what's going on in their broad life as a holistic individual. And this is why that interdisciplinary, broad psychosocial approach is so essential to supporting patients with particularly chronic pain. And so this is where we lean on our colleagues, including social work, First Nations, Métis Health, spiritual care, and others who can come alongside to help support that. There are also other support groups. So the Multiple Myeloma Support Group. The SHA has a Live Well with Chronic Pain workshop. And so I just put these up here in terms of some of the information about how to access those, but those could serve well, especially those who have more ongoing chronic pain, which many of our myeloma patients will. Okay, now I want to shift to talk a little bit more about the pharmacologic symptom management. So this is the stuff in orange. Again, there are various versions of this latter, but they generally categorize it as mild, moderate, severe, and then some have the persistent severe. Despite the interventions of step 3, they still have persistent severe. Again, I'll just reference there is this learning module that you can do for free if you want that will go into some of this with more detail, but I'm going to go through some highlights as well as a few unique things for myeloma. So the main principles are by the ladder, by the mouth, by the clock, with the PRN, and anticipate side effects. We're going to go through each of these in turn. So by the ladder, this means, again, depending on the severity of the pain, that should guide what type of treatment pharmacologically you're using. So for mild pain, this is the non-opioid thing. So acetaminophen might play a role in this. Again, if it's acute, less than 10 days, up to 4 grams. If you are using it more than 10 days, generally it's recommended to do no more than 3.2 grams. NSAIDs largely should be avoided in patients with myeloma, partly because of their nephrotoxicity. So again, some of our patients will already have established renal impairment. Others are at risk of it, and we don't want to accelerate that. So in addition to that, there is the increased GI bleeding risk. And that would be especially if people are on concurrent corticosteroid, which could be part of their treatment regimen, or if they're on anticoagulation because of a clot, which again, this patient population is at a higher risk for. That being said, topical NSAIDs might play a role. Now, something like this, 10% diclofenac, it's a compounding pharmacy that would have to do it. But it is potentially useful for bony pain in areas where there's not a huge amount of interposing tissue. It can just be applied topically and can play a role. Now, for moderate pain, this is again that kind of 4 to 6 on the scale out of 10. You notice I put a question mark by the ladder. A lot of people in the palliative world would suggest that step 2 should be bypassed altogether and go right to step 3. This is avoiding the weak opioids and going right to the strong opioids, but using a lower dose if it's moderate pain. Now, what is that rationale? Well, let's talk about what are these weak opioids. So they're codeine and tramadol. Codeine, as you probably know, it's a prodrug. So it is metabolized into morphine, and that's how people get the analgesic effect. It's from the morphine that their body creates from the codeine. The reality is, though, that different people metabolize it differently. Most people have a certain percentage that's metabolized, but some have none. They get no morphine out of it, and some are super metabolizers where they get kind of a surge of morphine. So a quote that stuck with me was, giving a known dose of codeine is the same thing as giving an unknown dose of morphine. If you want somebody to have morphine for their pain relief, why would you give them an unknown amount when you could give them a known amount? In addition, the metabolites increase the risk of opioid neurotoxicity, and there's dose limitations. So definitely if it's combined with Tylenol, there's only so much that you can take. But even if it's plain codeine, like whether it's immediate release or slow release, there are limitations. You can only reach a ceiling and then you have to stop. What about tramadol? So this is the other so-called weak opioid, but reality is that it's an SNRI, and it is then metabolized, and a portion of that, a small portion, becomes an opioid. And so it is kind of giving an unspecified amount of an opioid and an unspecified amount of SNRI to a patient because that metabolism is variable from person to person. This also, there's only so much you can give, maximum doses, and there are some potential risks, increased seizure risk, especially if people are on other serotonergic agents, if they're on an SSRI for depression or anxiety or metoclopramide, higher risk of serotonin syndrome, hypoglycemia risk. It's also just expensive, and it's not covered by palliative drug coverage. So the bottom line is I probably never initiate codeine or tramadol in patients. If somebody comes in and they're on it and it's working very well and they're tolerating it and there's no contraindications, perhaps we'll continue it, but I'll plant the seed to say there might come a time when we might need to shift to something that could potentially be better. So again, recognizing that many of our patients will experience moderate to severe pain, opioids and particularly strong opioids are a mainstay of treatment. We also have to recognize that, again, renal dysfunction is a common complication in those of our patients who have multiple myeloma. So let's just talk about what opioids we should avoid when people who have more advanced renal dysfunction, specifically if their creatinine clearance is less than 30. Don't use morphine, don't use codeine, don't use tramadol, and probably don't use oxycodone. Preferred ones would be hydromorphone. Again, it does have metabolites that are renally excreted, and there can be some risk, but it certainly can be used. You just have to have a little bit more caution. Methadone is great, and fentanyl if somebody's opioid tolerant. So don't start a fentanyl patch in someone who's opioid naive. I also just want to highlight that opioids play a big role in both nociceptive and neuropathic pain, and cancer-related bone pain often has a neuropathic component. In some studies, up to 70%. And so that being the case, this is why methadone might play a special role in caring for patients with multiple myeloma with all the bone disease. Because it's not only an opioid agonist, but it has that NMDA antagonism. And so this can be sometimes more effective for that mixed neuropathic nociceptive pain. I can think of patients even very recently that I've cared for who have had like really horrible cancer-related bone pain and just inadequately controlled with various opioids and adjuvant agents. And then some methadone was introduced and it had surprising and dramatic improvement. So this can be used as like a first-line opioid in an opioid-naive patient, or you can layer it in as an adjuvant to existing opioid. Now, that being said, there is a stigma around methadone, and this is sometimes sort of just in the general public. It's associated with only for people who have opioid use disorder. There's also some, I think, stigma and fear around using methadone among providers. Now, to be sure, it is a drug that has some risk to it, and so it does require an experienced prescriber. But the reality is many of you are probably prescribing other drugs that have similar risk profiles. And I do think methadone is really, really helpful tool to have in your toolkit. So if it is something you want to learn about more, I'm going to direct you to this Canadian Virtual Hospice Methadone for Analgesia course. This was developed specifically for patients with palliative needs and how methadone can be integrated. It's a great free online course that provides a lot of good guidance. So we talked about by the ladder, now by the mouth. Basically, this just means we prefer the oral route, so long as they can swallow and you're not worried about GI absorption. By the ladder, by the mouth, and by the clock. This is that for those people who have ongoing pain, which many of our myeloma patients do, they need scheduled analgesics. Don't just rely on PRNs. And so if you're using a strong opioid like morphine, hydromorphone, or oxycodone, usually we start with scheduled immediate release every 4 hours. Once the pain is better controlled and we know how much opioid they need to have adequate pain control, they're not needing tons of PRNs, then we switch to the sustained release. So this is the idea that an immediate release product, usually you kind of get this surge in the concentration of serum and lasts about 4 hours. If you schedule it every 4 hours, you're trying to achieve just a bit of a stable baseline where that serum concentration of the drug is in the therapeutic range to hopefully stay ahead of the pain and not merely be playing catch up. So at the beginning, we're often doing this, and that includes like overnight, setting an alarm and taking it. And many patients who have severe pain are not sleeping well anyway. So that is not too onerous. But ultimately, when the pain needs are better known, we're going to switch to a sustained release product. Often it's a Q12 hourly one with the same purpose. So by the ladder, by the mouth, by the clock, and with a PRN. This is an immediate release opioid because it's to treat episodes of breakthrough pain. We often dose at Q1 hourly PRN, or perhaps Q2 hourly in the frail, elderly, or multimorbid patients. Now that might seem really dramatic for some people, like every hour, that seems risky. That seems excessive. Well, it's not that we want or expect people to take it every hour, but it's we want the option of being able to do that. And this has to do with the basic pharmacology. So when you take a dose of an immediate release opioid, say morphine or hydromorphone, you begin to see effect within 30 minutes orally, and then by 1 hour, you're pretty close to the peak serum concentration. So if you're having 9 out of 10 pain, and you take a dose of immediate release hydromorphone, and an hour later it's down to a 7, the concentration is probably not going to get much higher after that. It will last for a while still, but it's not going to be that much higher. So we have the option of topping up. Now, when we start, this is somebody who's just initiating opioids, often we're using the same dose for the PRN as their scheduled Q4. So for example, if somebody's on hydromorphone 1, Q4 hourly scheduled, I would often do 1 milligram Q1. Once they're on an established opioid regimen, the way you figure out the PRN dose is that the PRN should be about 10 to 15% of the total scheduled dose. So for instance, if somebody was on hydromorphone SR9 BID, that's 18 milligrams in 24 hours. So we want about 10 to 15% of that. So 2 milligrams to get that 10 to 15% Q1 hourly. So this is just, again, maybe some thoughts. You'll see variations on this, but for the non-frail, non-elderly with more severe, moderate to severe pain, hydromorphone 1 milligram or morphine 5 milligrams. Most people regard them as kind of a 5-to-1 ratio. If you're using methadone, might start with like 1 milligram Q8 hourly, it's longer acting, and then use hydromorphone or some other immediate release opioid for the PRN. For the frail or elderly, it's just a reduced dose. And then for the PRN, maybe a reduced frequency like Q2 hourly. For the very frail or very elderly, very multimorbid, you can be even more cautious. You can always give more, but you can't take it away once it's given. So we're more cautious. You notice maybe in the methadone might even do Q12 hourly in this patient population. Essential is to educate and anticipate side effects. So you need to let patients know about some of the common side effects. If they're appropriately dosed, usually drowsiness isn't a huge problem. If people have real problems with drowsiness, more often than not, they had a higher dose than might have been indicated. But even if they do have drowsiness, reassure them that often it improves as the body develops some tolerance. Most people don't get nausea with opioids, but some do. And so prepare them for that and have a PRN antiemetic. For opioid-induced nausea, I would often suggest metoclopramide or Haldol, and let them know that it also usually improves. If it doesn't get better within a week, then probably switch to a different opioid. Constipation, we must counsel and prep our patients for success. It's far too many patients who give up opioids or are hesitant to use opioids and have uncontrolled pain because they had terrible constipation that wasn't proactively addressed. So this is, for almost all patients, opioid will cause constipation if it's used regularly. So we need to prep them for that. So usually a scheduled opioid means a scheduled laxative. It's the old saying, the hand that writes the prescription for the opioid must be the hand that writes the prescription for the laxative. These are medications that have some risks, so we need close follow-up, usually within 2 or 3 days. That could just be a phone call, but it could be an in-person visit. And then that they have advice how to seek help sooner if there were more concerning features. In that follow-up, we want to review how are you doing with side effects? What is their PRN use? Again, our goal is to have their pain adequately controlled with hopefully no more than 3 PRNs per day. So let's talk about titrating opioids. There is no absolute ceiling dose for strong opioids. The ceiling dose is generally just when you increase it further and that doesn't give any more help or it becomes intolerable. So I let patients know, so long as the opioid is indicated, so long as it's effective, like it's actually helping you, and so long as it's tolerated, we'll continue to nudge it up. Same thing with PRNs. If they are helpful and tolerated, but they're needing them a lot, then that generally means we have to increase their scheduled. I compare it to insulin. If it's somebody needing tons of correction insulin, that usually means we have to increase their scheduled insulin. If somebody's needing a lot of PRNs and they're helping and they're tolerated, then we need to increase their scheduled. You just kind of take the average amount of PRN that they're using and integrate it into the scheduled opioid. And then you recalculate the PRN with that new 10 to 15% of the daily dose. So for instance, let's say someone's on hydromorphone SR12 BID, so that's 24 milligrams scheduled. So their IR is 3 milligrams, which is kind of in that 10 to 15% range, but they're needing 4 PRNs essentially every day, and it's helping and it's tolerated. That's an extra 12 milligrams of hydromorphone. So I would just integrate that into the scheduled, increase the SR to 18 BID, and then that's 36 milligrams a day. So recalculate the PRN to be about that 10 to 15%, giving us 4 milligrams. Now, just a word of warning about titrating opioids. So if there's any scenario where a patient has like an acute and dramatic increase in their PRN use, that should be a red flag. Don't just reflexively increase their doses. You must consider and rule out, is there opioid-induced neurotoxicity, altered mental status? It could be subtle, myoclonus, allodynia. Or is there maybe some acute event? Have they had a vertebral compression fracture that needs to be explored and identified? Or is this an evolving spinal cord compression? So make sure that those are on your mind if there is a dramatic increase in PRN use. Briefly, corticosteroids. So again, these might be a part of the actual treatment regimen for the multiple myeloma patient, but they can also sometimes play a role in acute management of pain. So let's say somebody had palliative radiotherapy for pain and they had a bit of a flare, they might have a role for some systemic corticosteroids. But for those of us who are not oncologists, we should talk with the oncologist prior to initiating, just because, again, they might have specific regimen that they're on already. Dexamethasone is most commonly used. So that's bone-related pain. I want to now talk about neuropathy a bit. So peripheral neuropathy, this can be either disease-related or treatment-related. The disease-related, this is from the deposition of those immunoglobulins. And a lot of patients who are ultimately diagnosed with multiple myeloma have had some peripheral neuropathy symptoms, like more often than age-matched controls. And so a neuroconsult, maybe EMGs or nerve conduction can help provide clues to it. If there is clearly a paraprotein neuropathy and then ultimately they are diagnosed with multiple myeloma, then systemic therapy should be initiated, obviously for the myeloma itself, but the neuropathy might improve with if it is disease-related. However, it's important that you rule out other causes of neuropathy, so diabetic-related, vitamin B12 deficiency, because if there's those other coincident causes, they're not going to respond to the myeloma therapy. And if they are untreated and worsening, you wouldn't want to have an inappropriate dose reduction or discontinuation of an effective myeloma treatment. So in terms of the treatment-related neuropathy, we also have to recognize that those who have a pre-existing neuropathy, they're at a higher risk for getting treatment-related neuropathy, so they need to be monitored. It's most commonly seen with bortezomib, which is used in different induction agents, as well as for non-transplant eligible patients. Thalidomide, not used as commonly at this point, but it is one of the higher risk for neuropathy. So some of the features of this, it is predominantly sensory, often with some pain, some of those positive phenomena, burning, paresthesias, in a Stocking glab distribution. In really severe cases, there might be motor or autonomic effects as well. Fortunately, it often improves in patients and might even completely resolve with an appropriate dose reduction. So it'd be obviously by the oncology team. Just quickly mentioning lenalidomide or pomalidomide, these are derivatives of thalidomide, and they fortunately have a lower risk of the treatment-related peripheral neuropathy. But the mainstay of treatment for true treatment-related neuropathy is dose reduction or discontinuation. Nonetheless, there will be patients who still have residual neuropathic symptoms, pain, burning, paresthesias, and there isn't great data to guide this management. So a lot of it just is based on management of other chemotherapy-related neuropathies. So I'll just talk about a few things in the literature. Acupuncture, there's not sufficient evidence to recommend. Some studies say it helps, some studies say it doesn't. So wouldn't necessarily obviously recommend it. There are potential roles for adjuvant treatments here now. So this is often leaning into the anticonvulsants. So pregabalin or gabapentin, again, just recognizing they are renally dosed. So if your patient has renal dysfunction, make sure you're dosing it appropriately. Pregabalin could be a good option if they've got comorbid generalized anxiety disorder, because pregabalin is a first-line treatment either for monotherapy or for adjunct for generalized anxiety disorder. Duloxetine, SNRI, which also has renal implications for dosing, but if somebody's got comorbid generalized anxiety disorder or depression, or even some of the other anxiety disorders, it could be kind of a dual effect for that. I mentioned that opioids have a real role to play for neuropathy and with unique advantages from methadone, so consider that. TCAs do play a role, but we just have to be cautious in the elderly population because of the risks associated. What about cannabinoids? Well, the benefit in just sort of generalized unselected cancer pain is still not totally clear, but there is evidence that it's potentially helpful in chronic neuropathic pain. So might be a benefit in patients with neuropathy in these scenarios. At the same time, there are potential downsides. This is just a little chart from the RX files. Many patients do have adverse effects, and they might not be, patient who's about to consider it might not be aware of how common these are. This is something just to bring up. At the same time, I also want to let you know that there is research being done to this. So one of our palliative colleagues, Pippa Hawley from UBC, she's working with the Pan-Canadian Palliative Care Research Collaborative and has been over the last few years doing a study about cannabis, specifically oils for cancer-related symptoms, including pain. And I recently attended a conference where she presented the preliminary data, and it was very exciting. And I think it's encouraging and will also provide some guidance for how we do this, because sometimes it's a bit of a black hole for some of us. Quickly, just talking about neuralgia, post-herpetic neuralgia. So again, infections are a leading cause of morbidity. And then some of the agents that are being used in the treatment of our patients do increase the risk of reactivation of the chickenpox virus. For those of us who aren't in the oncology world, it's important to recognize that those who are seropositive for VZV, they had chickenpox in the past, if they don't have prophylaxis, transplant recipients, high risk of recurrence, reactivation, but that dramatically decreases with prophylaxis. So herpetic and post-herpetic neuralgia, this is, of course, a localized neuropathic pain in a dermatomal distribution. They've often got like sensitivity to touch, hyperalgesia, burning, paresthesias, electric shocks. We call it post-herpetic neuralgia if it's greater than 90 days after the episode. What can we do to help them? If it's constant and burning pain, a TCA has the best evidence. If it's more intermittent, kind of episodic spurts of electric jolt pain, then a gabapentinoid is probably preferable. There are some other topical treatments that can be considered, might require a compounding pharmacy and might be more costly. I want to briefly just talk about multidimensional pain. So this is the reality, again, that pain is a multidimensional experience, and we are multidimensional individuals. And so it's a phenomenon where the source of a patient's pain is not only physical, but has contributions from other domains as well. And so this requires a multimodal, multidisciplinary approach. There could be fear of disease recurrence. There could be concurrent mental health concerns, other stressors in their life. And so this is integrating this more holistic approach. Cicely Saunders, who was the founder of the hospice and palliative care movement in the modern age, coined the term of total pain, which talks about how it's not just physical, it's not just tissue that's being damaged, but there's other things that are informing and contributing to the pain experience. Psychological sources, social sources. She even talked about bureaucratic sources of pain, which I can resonate with. And so while we do have to treat tissue and symptoms, the reality is often there isn't active tissue damage that's going on here. And so you can't just rely on pharmacologic agents. You must do more of a broader approach. And part of that, just to close here, is symptom management. And so there are amazing handbooks and resources available from Myeloma Canada, like truly excellent. And the SAS Cancer Agency is developing an increasing number of resources on their website. So this is a general handbook that can be downloaded or ordered or printed. They've also got specific handbooks for pain and fatigue or other things. The last thing I'm going to mention before we close is just a few prescribing considerations. Again, we're recognizing that patients can live for many years with multiple myeloma and have moderate to severe pain at many points along that journey. So they might need chronic opioids. There can be fear around that from patients, stigma around it, understandable worries in the setting of an opioid crisis. So we have to address those, but at the same time, we must be attentive to the risks and burdens of chronic opioid use. So it's imperative that we're screening patients for opioid use disorder. We'll talk about the ORT briefly, but this is a validated tool, both at initial time of prescribing and throughout kind of refills of prescriptions to having that on the radar. And then just having safe, responsible practices, especially for those who are at higher risk of developing opioid use disorder. So that might be an opioid agreement, changes in your prescribing pattern in terms of how frequently things are dispensed, et cetera. And then also proactively introduce the notion that we might want to wean some opioids in the future, and there might be an appropriate circumstance. If you have palliative radiotherapy that's effective, many people can reduce their analgesic dose. So planting the seeds in advance that weaning might be part. If you're unfamiliar with it, this is just an excellent tool to use to screen for opioid use disorder. They talk about low, moderate, and high risk patients. And again, you should just have more precautions in those who are moderate to high risk. I'm all about patient handouts. There's some great ones from Canadian Virtual Hospice that address some kind of common concerns about opioid use among patients, as well as how to use them safely, like real sensible considerations. And those can be downloaded from Canadian Virtual Hospice. The RX Files has a tremendous resource for patients who perhaps would benefit from having their opioids tapered, but there might be some worries that they have. This is a great resource. And finally, RX Files has a great paper in their chart that talks about how to taper opioids. I would generally recommend that in myeloma patients, we use the slow and gradual taper. I often am doing like 5 to 10% every 2 weeks if I'm doing this. There are other approaches, but for most of us, we would do the slow and gradual taper. But this is a great resource just to point out. Okay, that is all I'm going to share right now. There is, again, a survey that can be done. I'm told it's very brief, just reflections on this as well as future sessions. And again, I do have supplemental slides for some of the other symptoms that we didn't address today. But thank you very much for your attention. And I'm happy to stick on. I know that we're just over the 1 o'clock mark, so many of you have to get back to work. Feel free to drop off the line, but if there's anybody who wants to stick on the line for more conversation, I'm happy to do that. Thank you so much.
Wow, that was phenomenal. It's a lot of information, but practicing myeloma now for, I don't want to say how many years, great